Good evening, everybody. I think already we are nearly half a century of people into this session. So we'll just wait for maybe another 60 seconds to 90 seconds before we start. It's a pleasure and privilege to have everybody in. And I can already see that there are quite a few of the people for whom it is intended for. Essentially, it's all started with the students of Apollo Gleneagles Hospitals, Kolkata, the DNB trainees at Apollo. But yeah, I think over the last couple of months, it has expanded, and we find that from the friends of the students that we have, it has reached to a lot more people. And we are planning to have this, we're trying to have this, rather, I won't say it is anymore in the planning thing. We're trying to have this every Friday. So let's see how far we go. And, the 1912 pandemic got the renaissance going for the whole world. I think this pandemic has given this modality of teaching and training to us. What I think, just I'll take you through, and possibly we will have a feedback from all of you later on. And I think I'll begin initially by thanking HCP Forum and especially Dr. Jayati for handling the entire back room and handling the setting up of this webinar. And she has been extremely helpful. She has the patience and the willingness to kind of take everyone through the route. And she's been also willing to help people in how to register, etc., etc. So we would just ask you, I think, to at the end of the session, please, you will receive a mail from HCP Forum. Please do fill up the mail, and we want to figure out how easy or how difficult the registration process is, so that we can try and make it better as days goes by. So I think we are good to go. We are hit 75 people. So I think Palash, I think we are good to go. So the agenda for today would be that Dr. Palash Kumar. Palash is a great friend of mine for a long time now. I've been knowing Palash since he was a student of anesthesia, pursuing his MD, and then he came and joined our department, and he was one of the bright stars of the department. He has helped in the progress of the Department of Anesthesia at Apollo. Huge contribution towards the progress, both clinically as well as academically. And then we started our own initiative like the Kolkata Anesthesia Academy. He has been he has had a huge role to play. So today, Palash will first take you through the investigations. The theme for this evening is the lungs, the pulmonary thing. And so he will take you through, and you can figure out that most of our sessions are kind of focused at postgraduate teaching, but it has obviously huge implications for people who are in practicing anesthesia as well. So Palash will take you through the basic tenets of chest X-rays, pulmonary function tests, and something which is new, which is cardiopulmonary exercise testing. So he will take you through that. And then we will have the question answer session on that topic, that is Palash's topic, on chest X-ray, PFT, or CPT. And if you have to ask anything else, please type in your question and in the chat box. You can see that there is a chat box for you. So please type in your question at the chat box. At the end of the first session, we'll have the question answer. And then I will take over and I will take you through essentially preoperative evaluation of risk factors. And we will speak about non-thoracic surgeries, pulmonary evaluation, and a little bit about how you can optimize prior to taking that patient up for surgery. So without further ado, Palash, by the time you start speaking, I think we will hit the 3-figure mark. So please take over, and I you over to Dr. Palash Kumar, who is currently a consultant anesthesiologist in the Department of Anesthesia at the Woodlands Super Speciality Hospitals, Kolkata. Palash, all yours.
Yeah, thank you, Shrikadda. And I must say that after I passed out my MD, Shrikadda has been sort of my idol and mentor, at the same point of time. And we have spent a lot of time together. We have used to conduct these kinds of sessions on a physical basis, mostly with students. But here, because of this lockdown and all these things, we can now entertain an audience which is larger. There are drawbacks as well. It's not as interactive as it is when I'm facing an audience and talking to them directly. So there are drawbacks and also. So the three things that we'll be touching today in this first session, one is basic interpretation of chest X-ray. So we're not going to look at a large number of X-rays and find a correct differential diagnosis. What we are going to do is to establish a framework for looking at an X-ray and establishing a sort of a guideline. Just like when we look at an ECG, we look at point this, and we come to a conclusion. Similarly, we need to do such a thing for X-rays also. We must have read about X-rays during our MBBS days, but during our MD days, the emphasis on X-ray is not so much. And also in our present clinical practice, most of the time, any patient with significant lung disease, we tend to get a CT or even an HRCT. But X-ray is a basic investigation. Not all patients can actually undergo a CT scan at all possible times. So chest X-ray remains a very valuable test which you often prescribe. So a brief overview of that. And then we will also have a brief overview of PFT, how to look at an PFT and what are the informations that we can get from a PFT, and CPEX, which is cardiopulmonary exercise testing, which is a big thing now. And at least in our part of the world, we are not using it CPEX, but CPEX is quite widely used in the first world countries. And this cardiovascular fitness, it is one of the measurements, very valid and important measurements of cardiovascular fitness. And cardiovascular fitness is one of the most important determinants of our length of our life, whether long or short. So CPEX is important. So all three things will be touching around. So first I will begin with the chest X-ray. Okay. This slide set is courtesy Dr. Shoikat Sengupta. He had prepared it, most of it. I have just made a few small adjustments to it. So please have a look at this chest X-ray. We will come back to this X-ray and combine whatever we have learned in the next 15-20 minutes and see what is the interpretation of this X-ray. Not a very difficult one, but there's a rather interesting twist to it. Okay. So first is ordering a chest X-ray. We often order chest X-rays for a patient, and most of the time, at least what I do most of the time, I just write CXR. I'm guilty of that, I must admit. So I do not properly prescribe a chest X-ray. So these are the steps that we must follow when we establish or when we prescribe or write a chest X-ray. One is that we must identify the patient and writing it for the proper patient. It's important when we are seeing a patient in the wards, then we are writing it for the correct patient. Indications for the procedure, we should know why we're offering it. Often we just write a chest X-ray just because anybody is old, or just because somebody is old, or from some very small complaint, but chest X-ray should be reserved only for patients who deserve it. We're not going into detail for indications of chest X-ray. What you have to write is the position in which we want the chest X-ray to be done. It can be done either in the supine position or in the erect position. If it is anything is not said, then you have to assume that the X-ray is to be taken in the erect position. However, there are certain, especially for patients who are very sick or has a trauma or sick lying in an intensive care bed, it may not be possible for them to take an erect chest X-ray. In those patients, a supine X-ray will be indicated. The other thing is anterior posterior view or a posterior anterior view. If anything is not specified, then the X-ray should be a posterior anterior view. That means the chest X-ray would be coming from the posterior aspect and going towards the anterior aspect, and the X-ray film, nowadays there is no film, just a digital receptor, just like our cameras. So that lies anterior to the chest. There is a gap between the person, the X-ray generator and the person, and the film or the receiver or the whatever, let's call it the film. The film is kept flushed with the patient's chest and the patient stands erect. If we are taking the X-ray in a supine position, then it will be an anterior posterior view. That is, the chest X-ray film will be behind the patient or in approximation with the patient's back. Usually if anything is not specified, then the chest X-ray is taken in an end inspiration, because end inspiration inflates the lungs and we want the lungs to be nicely visualized. However, there are certain situations when you want an end expiration. That means less amount of air within the thoracic cavity, especially if we want to detect some abnormal air somewhere. So if we can reduce the normal air inside the lung and increase its density, then abnormal air, there is a contrast between these two things. Anything that is visible on a chest X-ray depends upon the contrast between two adjacent pieces of tissue. So if the patient is suspected of having a pneumothorax or atelectasis or some kind of air trapping, then an X-ray in an end expiration position at the end of expiration is justified. Well, shades of gray, not exactly 50, but only a few ones. This is a rough guideline towards looking at a chest X-ray and looking at the shadow. It's a gray scale, what is to be expected depending on the kind of shadows. On the very left, we have a black area, that means it is a completely radiolucent area. So that means what is there is air. And if it is a dark gray, then it is also very lucent, and the most likely tissues is fat. So we'll find fats around the skin areas and that. Soft tissue is lighter gray, like the heart and some of the blood vessels, etc. would be softer tissues. Bone would be almost near to white, slightly off-white, and something which is the whitest would be a piece of metal. There are various things which are implanted in the chest, so they will appear as white. We can also have artifacts like coins in the patient's pocket or maduli or tabik, this kind of stuff, or foreign bodies like bullets or ingested materials anywhere within the thoracic cavity. So this must be kept in mind when we are interpreting an X-ray. So how do we begin to interpret an chest X-ray? This is a stepwise approach. First, you have to confirm the details, patient, in which position the X-ray was taken. Then we have to confirm or see that the image quality of that chest, the image quality of that X-ray must be good for us to interpret it. Then we have to do a systematic examination to come to a conclusion. Here we will follow an ABCDA method: airway, breathing, circulation. That means circulation would be heart and the great vessels, mostly the heart. D for diaphragm, and then everything else. There is another approach which is followed, which is inside-out approach. Then the examination begins at the center of that chest and then goes to the periphery. But this is quite convenient. We are used to ABC following this dictum and algorithm most of the places. So we'll follow that. So patient's name and date of birth, date and time the film was taken. These things should ideally be printed on the chest X-ray. There is a tag which is placed, which usually has some kind of patient identifier and date and time the film of the taken. And there is also something else is usually there. A side marker is there. So a left or right L or R mark would be there to indicate which side of the patient is there. But we have actually we cannot verify whether this left and right is correct. I have faced X-rays in which the left and right was wrongly, that was in the wrong place. So left appears as right, right appears as left. So you have to be careful. If you feel that there is a possibility, then you will have to cross-check. Any previous imaging, if present, should be available for comparison. Now we come to the assessing of the imaging quality. Now here also we'll use an acronym. It's called RIPE. So R is for rotation. Now when we're taking an X-ray, the patient should be in erect posture and the patient faces a very flat wall and is almost pressed on this.